Well, good morning, everyone. It's a pleasure to be here. I'm going to be talking managing toxicities of hematologic malignancies focused on the novel agents. The novel agents I'm going to focus on are CAR T cells, bispecific antibodies, which are also called T cell engagers, and then checkpoint inhibitors. You had a wonderful presentation by Dr. Sai yesterday, so I'll try and add to what she had shared with you. The focus is going to be on lymphomas because that's where the greatest advances are, and candidly, that's where I live, that's where I do my research. So these are my disclosures, a founder of some biotech companies. The other candid disclosure, because I don't normally talk on this topic, I did it all with artificial intelligence, and it literally took 60 seconds to get all the slides that are not illustrations, so I'll be curious to see what you think of that. So CAR T therapy, in the non-Hodgkin's lymphomas, we target CD19. And here you see a typical construct. So essentially what you're doing is taking a human monoclonal antibody that recognizes a specific target, in this case CD19, and you're genetically inserting it into a T cell. And so the T cell is carrying the antibody to the targeted site where you get destruction of the malignancy, in this case the lymphoma. And the construct has within it not only the antibody binding portion, but there's a portion down here called the co-stimulatory molecule. It becomes very important. This one happens to be 41BB, which allows for the CAR T to circulate for a prolonged period. There's an alternative co-stimulatory molecule, CD28, which tends to give you a much more robust initial response and more activation of the T cell, and it enters into the toxicities that I'll mention. Now, how many in this room have actually treated a patient with CAR T? So just very few. So I'll just walk through the process, and that's in your right. You leukapheresis a patient, and after leukapheresing the patient, you take this construct and you're going to enter the patient's T cells that have been activated. Now, the construct is typically either a lentivirus or a gamma retrovirus. Those are the constructs that carry the genetic information. One of the things to be aware of is that they insert into the genome of the T cell. They actually insert into the genome. And so there are case reports of patients with B cell malignancies developing T cell lymphomas because of the insertion in a spot that affects an oncogene or tumor suppressor gene. But those are rare. You then expand this T cell population, and that can take a few weeks. Sometimes you have to do bridging therapy until the patient is prepared for the CAR T. Then you have to give lymphodepleting chemotherapy. It's usually fludarabine and Cytoxan at low doses for 3 days. And then there's an infusion of the CAR T. At the City of Hope, where we've done about 2,000, most of the patients are in our hotel adjacent to the hospital unless they develop a side effect. Now, when we talk about the bispecifics, and again, this is in the non-Hodgkin's lymphoma, here they're typically targeting CD20, very much like Rituxan. And in this instance, it's off the shelf. You're literally taking an antibody that recognizes the T cells, so the CD3 on the T cell in one of its arms, and then recognizing the malignancies through the CD20 connection. And the T cell, when it engages the malignant cell, releases perforin and granzymes, which essentially destroy the malignant cell. So what are the side effects? The main side effect is the cytokine release syndrome. With the bispecific antibodies, we have the luxury of gradually increasing doses, and so we can ameliorate this side effect. But with CAR T, it's that one infusion, and then you start to see the side effects. And so the cytokine release syndrome is a massive activation of CAR T cells and other immune cells, and then you get release of these pro-inflammatory cytokines, IL-6, interferon gamma, TNF alpha. And in the clinical features, mild cases, fever, fatigue, myalgias. More severe, it could be hypotension, hypoxia, capillary leak syndrome, organ dysfunction, especially cardiac and renal. And then the onset duration, the median time, this is for one of the products, Axicell, Tisacell, which has that CD8 co-stimulatory molecule, the one that leads to a more rapid activation. This occurs usually at days 2 to 3. And then Lysacell, which has the 4-1BB, the co-stimulatory molecule that gives for a longer duration of CAR T, but not as robust initial response. It's out at about 5 days. The range is a few hours up to about 14 days, and the earlier onset is seen with higher tumor burden and more rapid CAR T expansion. There's a grading system, as you see on this slide, and it starts with grade 1, which is low-grade fevers, and then grade 2 includes hypotension, and then grade 3 to 4, where there's more severe hypotension and hypoxia. In terms of management, early on we'll use antipyretics, IV fluids, oxygen. If the reaction is severe, we'll use tocilizumab, which is an IL-6 receptor blocker. It's very effective. We typically use this for greater than grade 2 cytokine release syndrome, toxicity. Corticosteroids are often used, methylprednisolone or dexamethasone for severe or refractory cases, and some patients have to go into the ICU. It's the minority of patients at this point. The other major side effect, which can be quite alarming, is the neurotoxicity. This is the ICANS. In terms of the pathophysiology, that's not fully understood, but involves blood-brain barrier disruption, endothelial activation, and cytokine effects. The clinical features are confusion, aphasia, tremor, seizures, in severe cases, cerebral edema, and coma. And the median onset is about 4 to 8 days. The range is about 1 to 21 days, with a median duration of 5 to 7 days. Probably what's most alarming to patients is they just have a complete memory loss. And it's fascinating, and then it gradually comes back. But again, not in everybody. There are now case reports of individuals who haven't fully recovered, and it's usually elderly individuals or individuals that had underlying problems. I had one acute experience with a patient of mine who had been a patient for many years and fortunately cured subsequent to CAR T, but had severe memory loss. And as she was coming out of it, she could remember my name, but not her husband's name. And that looked so. The grading, often we base it on orientation, name writing, attention, command following, and the management is predominantly corticosteroids, and we also use antiepileptics. The levetiracetam, that's actually Keppra. All the patients go on Keppra, and we avoid tocilizumab monotherapy in particular because it doesn't have very good penetration into the central nervous system. There is a medicine, anakinra, which is an IL-1 receptor agonist that's often used, but it's not FDA approved at this juncture. And some people have also tried thiamine with mixed results. And so ICU care is sometimes needed in severe cases. And then there are cytopenias. And if you have cytopenia, often it's handled through transfusions, or we give G-CSF if it's neutropenia. We try and hold the G-CSF until the cytokine release syndrome has resolved, otherwise you'll exacerbate it. And then infection prophylaxis is important in the neutropenic patient with antimicrobials, antifungals, and antivirals as needed. The last major issue is hypogammaglobulinemia, which is also the case in the treatment of the myeloma patients, because you're not only depleting the malignant B cells, but you're depleting many normal B cells. And so IVIG replacement occurs if you have recurrent infections or if the IgG is less than 400 milligrams per deciliter. And then gradually with time, we see some recovery. I'm now going to switch to the use of checkpoint inhibitors. So the central cell is right there up on top. That's the T cell that does the killing, and we want this T cell to kill this tumor cell. The T cell recognizes the tumor cell through specific antigens on the tumor cell, but those are usually presented to it by antigen-presenting cells like dendritic cells, which pick up these peptides and then through the MHC show it to the T cell receptor, which activates the T cells. Well, it turns out that the T cell will then express on its surface activating molecules and molecules that can suppress its function. One of the ones that can suppress its function is PD-1, which is the programmed cell death receptor. And you have on the tumor cell PD-L1, the ligand to this. So that will essentially blunt the immune response against the cancer. There are also parenchymal cells like myeloid-derived suppressor cells that will express PD-L1 and they'll dampen the T cell response. And so Jim Allison's Nobel Prize work, which was initially not accepted by many, was that if you block this phenomena, the immune system will be activated and kill the cancer cell. If there's nothing else you take home from my presentation, watch the documentary on Allison called Breakthrough. Everything he had to go through to get this to be a product that has such now a profound effect in oncologic care. And I think in terms of revenue generation, I don't think anything generates as much revenue as the checkpoint inhibitors. But it's another paradigm shift that took an enormous amount of effort. So how do we manage the side effects and what are the side effects of these checkpoint inhibitors? And so they work by blocking PD-1, PD-L1, CTLA4, which stands for the cytotoxic lymphocytic associated protein 4. And there are specific antibody inhibitors against PD-1, PD-L1, and CTLA4 is listed there. And while these therapies can be highly effective, they also carry the risk of immune-related adverse events due to an overactivation of the immune system, essentially creating autoimmune diseases. So here are the common side effects you see with the checkpoint inhibitors. On the left, you see the organ system. On the right, the common toxicity. So when you're treating patients with a checkpoint inhibitor, it's the common toxicity that you'll be looking for. If it's the skin, it's the rash. If it's GI, it's diarrhea. For the liver, it's usually elevated liver enzymes. For the endocrine, often we'll be checking thyroid functions as we're treating the patients. The one that may be most challenging is the hypophysitis, which is essentially the I would say pineal gland, but it's not the pineal. It's that small gland in your head, which I'm blocking, all right, pituitary. And often they'll have headaches or visual issues. For the lungs, pneumonitis, kidney nephritis, neurologic will be peripheral neuropathy. Fortunately, rare is myocarditis, and as well as the hemolytic anemia. And they tend to have different timing of onset. The skin tends to be the first at 2 to 3 weeks. GI follows at 6 to 8 weeks on average. Liver about 8 to 12 weeks. The endocrine varies. Often a later onset can be also persistent. And lung pneumonitis is uncommon, but when it happens, it can happen at any time. And if you start the patients on steroids, it's got to be a very slow taper. So the management strategies, again, prompt recognition, regular lab monitoring, steroids as first-line treatment, and then other immunosuppressants as needed. Infliximab, it's a TNF-alpha inhibitor. Dr. Tsai mentioned some others last night that are in that family. She also mentioned that you can now use JAK inhibitors or IL-12, 23 inhibitors. Those are more investigational, not FDA approved, but very effective. Mycophenolate mofetil for hepatitis. That's essentially an immunosuppressant that affects a dehydrogenase that leads to a decreased amount of guanine. And as a result, it affects the T cells. And then immunoglobulin replacement or plasmapheresis for the neurologic toxicities. And then the endocrine therapies are usually replacement, whether it's thyroid, steroids, et cetera. So I want to end by just mentioning the issues relevant to pregnancy. Essentially, you shouldn't get pregnant if you're on a checkpoint inhibitor. It has significant consequences to the fetus. And it's because the immune system is overstimulated. There are a variety of fetal antigens, and you can block these antigens, and it results in fetal rejection, miscarriage, or placental insufficiency. And even in the preclinical animal models, this was witnessed. There's also placental transfer of the immunoglobulin molecule, the checkpoint itself. Using here as an example, the two that are against anti-PD-1. And all portions of the pregnancy, each trimester, there can be an impact. And so you can get fetal immune dysregulation, growth restriction, and neonatal immune complications. So the current guidelines are that pregnancy is contraindicated, not recommended, unless their benefits clearly outweigh the risk. Once you deliver the child, then, or I shouldn't say once you deliver a child, I'd say that once you complete therapy, we feel you should wait 4 to 5 months before contemplating getting pregnant. And in terms of pregnancy planning, again, to wait till after you're off therapy several months. There also is an issue with breastfeeding, because in the breast milk will be the antibodies, and that can cause immunologic consequences to the child. And so you have to be very careful. And with that, I will conclude and show you a pretty picture of our campus. Thank you very much.
Dr. Rosen, we have a few minutes for questions, if there are any. All right, well, thank you.
Thank you.
And for our next